Mention borderline personality disorder in 2025, and chances are people still imagine chaotic relationships, endless hospital visits, or someone too broken to heal. But that story no longer fits the evidence, and the newer research paints a very different picture. Using the latest clinical and epidemiological updates from 2024 and 2025, we'll look at who actually gets BPD, what most likely causes it, and why recovery is far more realistic than people assume. And once we clear that up, we can start with the biggest surprise many people missed: how common BPD really is today, why prevalence numbers changed in 2025, understanding why the reported prevalence of borderline personality disorder shifted so noticeably in 2025 requires stepping back to look at how earlier research was designed. For decades, most of what we knew about BPD came from fairly narrow clinical samples. Patients who were already in psychiatric treatment, usually younger, and very often women. That shaped both public stereotypes and professional assumptions. But over the last few years, larger and more representative studies, spanning 2023 through 2025, began pulling data from varied ages, genders, and community settings. These expanded samples showed a much different picture of who lives with BPD and how often it actually appears in the population. Rather than being confined to a very specific profile, the condition is distributed more widely than anyone had formally documented before. The new prevalence estimates are part of why the conversation feels so different in 2025. In the general adult population, lifetime rates fall somewhere between 0.7% and 2.7%. That may sound modest, but the numbers climb sharply in clinical environments. Among people in outpatient psychiatric care, around 11 to 12% meet criteria for BPD, and in inpatient psychiatric wards, it can be as high as 22%. Those numbers make sense when you consider the intensity of symptoms, but they also highlight a crucial point. This is not a fringe diagnosis affecting only a few individuals. BPD shows up at every level of care, meaning far more people have been touched by it, personally, in their families, or in their workplaces, than the old statistics suggested. One especially important correction in the new data involves assumptions about gender. Earlier studies created the widespread belief that BPD occurs mainly in young women, because that group was heavily represented in therapy and hospital samples. The newer, broader research makes clear that men also experience BPD at nearly the same overall rates, yet they are often overlooked. This underrecognition traces back to how symptoms present differently. A woman struggling with BPD might be described as emotionally intense, anxious about closeness, or prone to rapid attachments. A man may be seen instead as aggressive, impulsive, or high conflict in relationships. Those outward patterns tended to lead clinicians toward labels like anger management problems, substance abuse disorders, or antisocial traits rather than considering BPD as the underlying driver. The effect was that many men lived with the condition for years without accurate diagnosis or treatment. Older adults were excluded in a different way. For a long time, the assumption was that symptoms ease markedly as people move into middle or later adult life. While impulsivity can decrease with age, other characteristics often persist. The updated research confirms that emotional instability, fear of abandonment, and feelings of emptiness remain central for many older adults, though they sometimes appear in softer or more masked forms. Instead of repeated self-harm, an older person might show withdrawal, persistent depression, or chronic complaints that don't respond well to standard medical care. Because those problems can be mistaken for natural aging, marital stress, or simple mood disorders, BPD often goes unrecognized after a patient's 20s. The expanded 2025 data, including samples from middle-aged and older adults, reveals that the condition continues across the lifespan more frequently than clinicians assumed. So why did it take so long to correct these views? A large part of the answer lies in diagnostic bias. Clinicians formed their mental picture of the typical BPD patient from decades of skewed clinic populations. When a young adult woman presented with turbulent relationships and emotional volatility, the fit seemed obvious. But when a man showed up with externalizing behavior or heavy drinking, or when a woman in her 40s felt empty and depressed, BPD wasn't the first consideration. That kind of pattern recognition shaped statistics, and statistics in turn reinforced the stereotypes. With the latest waves of more balanced data, researchers confirm that the condition is not confined to these narrow stereotypes. It is spread across genders and persists through adulthood. So what does this mean? It means that many more people may have gone for years without appropriate care. Men who were told they had just addiction issues, or older adults written off as simply depressed, were in fact showing manifestations of BPD that clinicians didn't recognize. Missing that diagnosis didn't just delay appropriate mental health support, it often came with added complications. Men with untreated BPD showed higher rates of co-occurring substance use and legal conflicts. Older adults faced both psychological and physical health challenges, including greater overlap with chronic illnesses like cardiovascular disease. When the root condition remained hidden, treatments targeted small pieces of the puzzle without addressing the whole pattern. There's also a broader social effect when prevalence is underestimated. If BPD is seen as rare or limited to one demographic, the rest of the population looks right past it. Families, workplaces, and schools may mislabel behavior, attach stigma, or withhold support simply because they don't think BPD applies to the person in front of them. This invisibility can make everyday life harder. People struggling are more easily dismissed as difficult, fragile, or angry, rather than recognized as living with a treatable mental health condition. Reducing that kind of distortion requires solid data, and that's exactly what the 2023 to 2025 epidemiological findings now provide. When researchers broadened sampling to rural communities, diverse ethnic groups, and different socioeconomic levels, another stereotype broke apart: that BPD was confined to young, urban, clinical populations. Instead, rates appeared consistently across backgrounds, showing variation but not exclusivity. That has a practical consequence. It means care systems have to adapt to find BPD in unexpected places. Not just psychiatric clinics in large cities, but general hospitals, primary care practices, schools, and workplaces. By building awareness into more environments, people are less likely to fall through the cracks for decades. The shift in prevalence data also changes prevention strategy. If only young women were thought to develop BPD, then early intervention would focus narrowly on adolescent girls in therapy settings. Now that clinicians know the condition affects people across age and gender, they're more likely to consider BPD in a wider range of contexts. Teachers observing persistent distress in boys, or physicians treating patients in their 40s with long-term identity insecurity, can add BPD to the list of possibilities rather than dismissing those patterns as phases or situational crises. That kind of rethinking improves the chance of early recognition, timely support, and better long-term outcomes. What ultimately stands out is how these updated prevalence studies confirm what many clinicians already suspected but couldn't quantify. BPD is more common, more distributed, and more relevant than the older data suggested. Far from being confined to a small community of patients, it threads broadly throughout society. Each correction to that picture is more than just a statistical footnote. It represents real people who may finally have their struggles understood in the right frame. And once you know the population is wider, you can't help but ask about the root causes. Why does this condition arise in the first place? And why might two people with similar experiences travel such different paths in mental health? Those questions take us to the next layer of the discussion: genes, environment, and that old nature versus nurture fight. Borderline personality disorder is often caught in the long-running argument over nature versus nurture. For decades, people leaned heavily on one side, assuming the condition came almost entirely from bad childhood experiences. That story carried moral weight, suggesting families were to blame and that individuals were scarred beyond repair. But it never matched the data. Many with BPD do report adverse experiences like neglect or abuse, but most people who live through hardship never go on to develop the disorder. At the same time, some people with no obvious trauma histories still receive the diagnosis. Trauma is neither necessary nor sufficient. Something else always shapes the outcome. Genetics turned out to be that additional influence. Twin and family studies revealed that the likelihood of developing BPD is strongly tied to heredity. When one identical twin has BPD, the other twin's risk is much higher than chance. Heritability estimates hover around 40% in StatPearl summaries and reach about 46% in large Swedish family studies. Still, researchers have never identified a single BPD gene. Instead, the risk is polygenic. Small influences from many genes combine to create a background vulnerability. This isn't destiny. It's best understood as a biological tilt, making someone more sensitive to environmental pressures one way or another. And, critically, These studies remind us that neither genes nor environment alone explain the full story. On the environmental side, unstable caregiving, neglect, and abusive households are more common in people later diagnosed with BPD. These environments can reinforce emotional instability and mistrust. But again, exposure does not equal inevitability. Many who live through extreme adversity avoid any diagnosable personality disorder, while others facing smaller stresses may be profoundly affected. The clearest conclusion is that environment can influence, but not define, outcomes. Genes channel how experiences stick, and experiences in turn affect how vulnerable genes are expressed. Epigenetics is how that translation happens. This field looks at how experiences can switch genes on or off without changing DNA itself. Stress in early life, for instance, can alter how the body manages stress hormones like cortisol. If a person already has genetic tendencies towards strong emotional reactivity, that exposure may entrench a stress response style that heightens future vulnerability. In another person, with different genetic buffering, the same environment may leave only mild effects. These gene-environment interactions mean BPD is never about a single traumatic moment or a single faulty gene. Instead, it's about the ongoing conversation between biology and experience. And importantly, epigenetic markers don't just switch in childhood. They can shift across the lifespan, which means therapy, supportive relationships, and even stress reduction later in life can reshape biological responses that once amplified BPD risk. This dual framework also helps answer a puzzle: why siblings raised in the same difficult conditions can take such different paths. Imagine two children in a chaotic household. One develops the unstable identity, mood swings, and relationship turmoil of BPD. The other does not. Looking only at environment makes this a mystery. But factoring in differential genetic sensitivity clarifies things. The child with heightened biological sensitivity absorbs stress more deeply, making BPD more likely. The other child, without that sensitivity, walks away with challenges, but not the full syndrome. Flip the scenario, and you find the opposite. Someone with high genetic vulnerability may never display BPD traits when raised in a stable, validating, protective family. Risk always comes from both sides of the balance. This perspective also lifts blame off families. While critical environments do matter, placing all responsibility on parenting ignores heritable vulnerabilities that parents cannot control. It also overlooks protective possibilities. Warmth, consistency, and social support can buffer even those born with heightened sensitivities. A validating environment does not erase risk, but it can bend developmental paths away from dysfunction and toward resilience. That shift is both clinically meaningful and deeply hopeful. Brain imaging has added one more layer of evidence. People with BPD often show overactive amygdala responses, linked to threat detection and emotional intensity, alongside weaker regulation from frontal brain regions. None of this is permanent damage or unique to BPD. These are patterns shaped both by heredity and environment. Chronic stress early in life may exaggerate the amygdala's reactivity, while supportive interactions help strengthen prefrontal systems that regulate strong emotions. Neuroimaging confirms what twin studies and epigenetics suggest. Genes invite certain vulnerabilities, but environment plays a constant role in shaping whether those vulnerabilities move toward illness or toward adaptation. The reality, then, is not a static scar but a dynamic system. Genes place some individuals on a more sensitive developmental track. Early adversity can nudge that sensitivity toward risk, but so can later stressors, and protective environments can nudge it back. Epigenetic mechanisms keep this process active across adulthood, meaning that life events, therapy, or supportive communities can still lead to meaningful change. This is why long-term psychotherapy reviews are encouraging. Meta-analyses covering multi-year follow-up periods find about 60% of patients experience remission of diagnosable BPD after sustained treatment. A significant improvement when compared with older assumptions that the condition was fixed for life. That improvement doesn't erase struggles, but it shows recovery is both realistic and statistically common over time. At the same time, gene-environment research does come with limits. Many studies are underpowered, meaning their sample sizes are too small to pick apart subtle interactions. Researchers caution against overly deterministic interpretations. No single study settles the question, and outcomes always reflect a mix of predisposition and lived experience. Accepting this complexity is not a weakness of the model. It is a more accurate description of how BPD arises and why people's trajectories can diverge so dramatically. Viewing BPD through this multi-factor lens helps shift how the condition is understood. It is not the inevitable result of bad parents, nor is it written immutably in someone's DNA. It is the product of inherited sensitivities influenced by an environment that can either harm or heal, with room for adaptation at every stage of life. That reframing matters, not only for those living with the diagnosis, but also for professionals trying to recognize and address it accurately. Because misunderstanding how BPD develops has fueled confusion in another critical area: the way the disorder is diagnosed in the first place. And misdiagnosis has shaped some of the most frustrating myths people still encounter. The diagnostic maze: why BPD gets misunderstood. One of the hardest challenges in understanding borderline personality disorder is that it often looks, at first glance, like bipolar disorder. Even well-trained professionals can mistake one for the other, which leaves many people carrying the wrong diagnosis for years. The similarities are not imaginary. Both conditions bring dramatic mood changes, impulsive choices, and tense relationships. But when symptoms are studied in detail, not just day to day, but across longer stretches of time, clear differences begin to stand out. Sorting those differences is what makes the diagnostic maze around BPD both complex and crucial. The confusion has roots in the early labels themselves. Borderline was originally coined to describe patients thought to exist on the border between neurosis and psychosis, while bipolar simply refers to alternating extremes of mood. Neither term offers a precise window into what the person is actually going through. That historical baggage adds to misunderstanding. So today clinicians pay less attention to the labels and more to specific patterns in how symptoms unfold. For viewers trying to keep the comparison straight, there are 3 quick contrasts worth remembering. First is the time scale of mood changes. In BPD, emotions can shift within hours or even minutes, often tied to an interaction or a perceived rejection. Someone may feel intense attachment in the morning, then spiral into despair or anger by nightfall. Bipolar disorder unfolds differently. Mood episodes usually extend over days, weeks, or even months, cycling between depression and periods of mania or hypomania. The difference in tempo, fast swings within a day versus longer-lasting mood episodes, is one of the most reliable distinctions. Second is identity disturbance. Identity disturbance, an unstable, shifting sense of self, is far more characteristic of BPD than bipolar disorder, and clinicians often use that to distinguish the two. People with BPD often describe not knowing who they are apart from their relationships, flipping between seeing themselves as all good or all bad, or abruptly changing goals and values. In bipolar disorder, identity is less affected. A person might adopt grandiose beliefs during mania, but these usually settle once the episode ends. That ongoing instability of self is a diagnostic anchor for BPD. The third contrast is treatment pathway. Bipolar disorder typically responds well to pharmacological approaches. Mood stabilizers, lithium, and antipsychotics form the backbone of treatment. Psychotherapy can help, but medication often makes the most immediate difference. BPD, on the other hand, does not show the same response to those medications. While medicine can help manage certain symptoms like anxiety or depression, first-line treatment is structured psychotherapy, such as dialectical behavior therapy, DBT, or mentalization-based therapy, MBT. Getting the diagnosis right isn't just about labels. It literally dictates which treatment will work best. Impulsivity, another shared feature, illustrates how easily the two conditions blur together. In bipolar mania, reckless spending or dangerous driving usually accompanies a surge of high energy and expansive mood. In BPD, impulsivity often stems from emotional overwhelm or fear of abandonment, even in the absence of elevated energy. The behavior, say, a shopping spree or sudden risky relationship, may look identical from the outside. But when clinicians dig into what triggered the episode and how long it lasted, the underlying mechanism reveals itself. Until recently, the accuracy of diagnosis depended almost entirely on detailed clinical interviews spaced out over time. In busy healthcare environments, that level of attention wasn't always possible. And because bipolar disorder is a more familiar and medically reimbursed label, patients were often given a bipolar diagnosis, even if the symptoms fit BPD more closely. The result was misplaced confidence in mood stabilizers, delayed access to targeted therapy, and years of frustration for patients who sensed something wasn't adding up. Newer research is beginning to untangle that confusion. Neuroimaging studies show that, on average, people with BPD more often exhibit overactive amygdala responses, reflecting heightened sensitivity to emotional threat, combined with less efficient regulation from prefrontal areas. In bipolar disorder, differences tend to appear in brain circuits tied to reward processing and longer-term mood cycling. Still, it's important to be cautious. Neuroimaging findings are mixed, vary by study, and only describe group averages. They cannot be used as a standalone diagnostic test. Researchers emphasize that imaging helps with understanding mechanisms, not with labeling an individual. The more practical diagnostic advances have come from refined psychological assessment tools and structured interviews. Evidence-based instruments, such as the McLean Screening Instrument for BPD or the Zanarini Rating Scale, allow clinicians to zero in on domains most relevant to BPD. Structured interviews like the SCID-5, PD add consistency, reducing the risk of clinician bias or rushed decision-making. By incorporating specific criteria, like frantic efforts to avoid abandonment, identity disturbance, or chronic emptiness, these tools make it easier to separate personality pattern instability from cyclical mood disorder. Both the DSM-5-TR and the ICD-11 have also updated how personality disorders are conceptualized. The DSM now offers both categorical criteria and an alternative dimensional model that evaluates levels of impairment in identity, empathy, intimacy, and self-direction. The ICD-11 goes even further, shifting entirely to a dimensional approach and using a borderline pattern specifier for individuals presenting with at least 5 defining features, such as unstable relationships, self-harm, or emotional volatility. These frameworks improve accuracy and reflect real-world overlaps in symptoms, rather than forcing individuals into narrow boxes. Of particular note is how strongly the revised criteria emphasize identity disturbance. Clinicians consider it one of the clearest dividing lines between BPD and bipolar. Patients can describe feeling like different people in different moments, struggling to maintain a coherent story of who they are. Bipolar episodes may disrupt judgment and mood, but in general, a person's baseline sense of identity remains intact when the episode passes. That difference in continuity of self versus episodic disruption greatly influences how clinicians interpret the broader pattern of symptoms. The implications of diagnostic clarity matter well beyond theory. Someone misdiagnosed with bipolar and placed on years of medication may never find lasting relief, all while wondering why therapy seems peripheral. Correct recognition of BPD, in contrast, routes them towards psychotherapy that builds emotional regulation and relationship stability. The change alters treatment goals, guides clinicians toward interventions that really fit, and increases the likelihood of meaningful progress. Misdiagnosis also reshapes the lived experience of patients. Being told in your 20s that you have bipolar disorder and later learning it is BPD can feel like more than a medical correction. It can feel like your entire understanding of self has been misdirected. Patients often describe such shifts as unsettling. Clinicians now recognize the need to minimize this confusion, not just for medical accuracy, but also to prevent a loss of trust in the therapeutic process. People deserve to know what they are facing and to feel that their struggles are being taken seriously the first time. Another subtle point is that external appearances can deceive. Two people may both appear irritable, reckless, or withdrawn. One is caught in the cyclical rhythm of mania and depression. The other reacts to an interpersonal trigger with acute swings in emotion and behavior. Without detailed context, both cases look similar from the outside. But understanding whether the driver is episodic mood cycling or ongoing relational sensitivity makes all the difference in how to plan support. Finally, clinicians acknowledge that categories themselves can overlap. Some individuals do, in fact, meet diagnostic criteria for both bipolar disorder and BPD. In such cases, a dual diagnosis is more accurate than forcing one label. The new structured tools make it easier to spot these mixed presentations, which ultimately leads to treatment addressing all aspects of a person's mental health instead of oversimplifying. By 2025, the diagnostic maze is no longer entirely impenetrable. With clearer clinical contrasts, timescale of mood changes, identity disturbance as a hallmark, and different treatment pathways, alongside tools that bring structure and precision, professionals are better equipped to tell the conditions apart. And while research continues, the shift already improves care by aligning people with interventions that target the real issue at hand. That progress sets the stage for an equally important question. Once the diagnosis is correct, what does effective treatment actually look like? Treatment breakthroughs, beyond just talk therapy. For many years, treatment for borderline personality disorder carried a reputation for being frustrating, lengthy, and uncertain. People imagined therapies that dragged on with little effect, repeated hospital stays, and a feeling that real change was out of reach. That picture was tied to misconceptions, from the idea that progress could only be slow, to the belief that no interventions worked reliably. What we now know in 2025 is that outcomes are significantly better, especially when therapies are applied in structured, evidence-based ways and supported by broader treatment systems. What matters most is not a miracle cure, but the steady accumulation of research showing which approaches deliver consistent benefits. A central part of that progress is dialectical behavior therapy, or DBT. This was developed specifically with BPD in mind, and it remains one of the strongest evidence-supported treatments today. DBT is intensive, combining individual therapy, group skills training, and structured coaching. What sets it apart is its focus on teaching skills that directly reduce self-destructive behaviors and improve emotional regulation. Clinical trials confirm its impact. Across randomized studies, DBT reduces self-harming behaviors and crisis episodes significantly compared to treatment as usual. A meta-analysis reported effect sizes around -0.60 for symptom severity, meaning patients improved by more than half a standard deviation over comparison groups. Its strongest evidence lies in lowering rates of suicide attempts and self-harm, which are among the most dangerous risks associated with BPD. Alongside DBT, Mentalization-Based therapy, or MBT, has gained traction as another structured, effective approach. MBT builds reflective capacity, the ability to understand one's own thoughts and emotions and interpret the intentions of others more accurately. Because people with BPD often struggle to interpret interpersonal cues, even minor conflicts can escalate quickly. MBT helps by slowing reactions, encouraging curiosity over assumptions, and widening the space between feeling and action. The method uses both individual and group formats, and therapists approach patients with empathic validation rather than confrontation. The goal is not abstract insight, but practical improvements in relationships and emotional stability. Another option, transference-focused psychotherapy, or TFP, makes therapeutic progress by paying close attention to how patterns emerge within the therapy relationship itself. People with BPD often switch between idealizing someone and then suddenly feeling betrayed or devalued. In therapy, these shifts appear in how a patient relates to the therapist. By naming and exploring those dynamics in real time, TFP helps the person develop a more consistent sense of self and more stable expectations of others. It is intensive, but especially useful for patients whose challenges center strongly on interpersonal instability. Schema therapy, or ST, brings yet another framework. It works on deeply anchored thought and feeling schemas that shape reactions. For BPD, these include recurring patterns such as the abandoned or abused child, the angry child, the detached protector, or the punitive parent. Left unexamined, these inner modes drive volatile emotions and self-sabotaging behaviors. Schema therapy challenges these patterns directly through cognitive restructuring, emotional work, and behavioral changes. One distinctive feature is limited reparenting, where the therapist provides experiences that model healthier emotional responses, which patients can then internalize as a steadier, healthy adult mode. Researchers emphasize that no one treatment has proven superior across all outcomes. Head-to-head comparisons suggest that specialized psychotherapies have medium effect sizes compared to usual care, with different models working better for different patients. DBT, MBT, TFP, and schema therapy are all valid frontline approaches. What is increasingly common in 2025 are hybrid programs that combine elements of these therapies. For example, a clinic might use DBT's structured skill training, incorporate MBT's reflective exercises, and add schema therapy techniques for entrenched thought patterns. The rationale is simple. BPD affects multiple domains: emotion regulation, sense of self, interpersonal relationships, and no single theory addresses all of them at once. By blending approaches, practitioners can match treatment strategies to a broader range of symptoms and needs. Integrated and generalist models also help expand access. Historically, only a handful of highly specialized centers offered DBT or MBT in full. But recent guidelines note that generalist clinicians can apply adapted forms of these therapies, weaving in evidence-based elements without a formal DBT team. Research indicates these generalist programs produce comparable results to specialist ones in many cases, especially when therapists have structured supervision and team consultation. Access to therapy matters more widely than theoretical purity, and team-based delivery reduces burnout, which has been a serious issue in BPD care in the past. The practical outcomes of these approaches are clear. Patients in hybrid or well-supported programs show fewer crisis hospitalizations, improved daily functioning, and reductions in self-harming behaviors. Studies also describe gains in work and relationship stability, areas often overlooked but central to quality of life. Importantly, psychotherapy now defines recovery in broader terms. It is not just about reducing suicide risk, although that remains critical, but also about building sustainable lives marked by improved emotional stability, stronger social connections, and a more consistent sense of self. Pharmacological treatment has a very different place in this picture. Clinical guidance is consistent. No medications are FDA approved for the core symptoms of BPD. Drugs are not recommended as frontline treatment. Instead, medication is reserved for acute and specific circumstances, such as severe depression co-occurring with BPD, short-lived psychotic states, or periods of extreme agitation. Even then, the recommendation is to use medication only for the shortest time feasible, and only when symptoms cannot be managed through therapy alone. Medications with dependence risks are particularly discouraged due to high comorbidity with substance misuse. The key message is that medication cannot replace psychotherapy as the foundation for treatment, but may have a role in targeted crisis management. Despite progress, therapy is not a guaranteed solution for everyone. Dropout rates remain high, and across studies, 40% to 50% of patients show limited improvement or leave therapy prematurely. This variability reflects the complex nature of BPD and underlines that while structured psychotherapies are powerful tools, they are not universal cures. Setting realistic expectations that recovery often requires sustained work, may involve setbacks, and varies across individuals, helps patients and clinicians stay engaged without the pressure of unrealistic promises. Clinicians also benefit from the growth of team-based care. Earlier eras saw high burnout among therapists who worked with BPD patients, in part because stigma painted those individuals as untreatable. Modern integrated models recommend regular team consultation as part of delivery. This system is not only for patient benefit, but also for therapist support. Shared responsibility reduces the risk of isolation, expands the pool of creative problem-solving, and helps sustain long-term therapeutic relationships, which are central to progress. The cumulative picture in 2025 is not one of a miracle cure, but of steady, evidence-informed progress. Specialized therapies like DBT and MBT have clearly demonstrated benefits. Hybrid frameworks broaden what can be offered, and generalist adaptations bring these tools to more people. Medication has a limited and carefully defined role, while psychotherapy remains the core engine of recovery. Most importantly, treatment now produces outcomes that directly challenge the old reputation of BPD as resistant to improvement. Patients are showing not just symptom relief, but real changes in relationships, stability, and identity. This redefined picture of treatment clears space for a deeper question about what happens after therapy begins to work. Because treatment is no longer only about managing symptoms, it is about the possibility of recovery itself, something that for years was doubted and rarely discussed. The recovery stories nobody talks about. The part of the conversation that often gets left out of discussions about borderline personality disorder is not the suffering, but the recoveries. These stories are quieter and less publicized, but they're essential. For decades, the narrative defined BPD as endlessly unstable, telling patients and families alike to expect little more than a lifetime of hospital visits and fractured relationships. That view was backed by stigma rather than data, and it discouraged many from believing in the possibility of change. In truth, long-term research shows a very different picture, one where recovery is not the rare exception, but a realistic outcome for many. One of the most influential reviews to examine this was published in 2024 in World Psychiatry. This review summarized decades of outcome studies and did something crucial. It replaced speculation with data. Rather than describing the outlook for BPD as grim or hopeless, it labeled the prognosis as fair. In research terms, fair means demonstrable improvement that lasts, not occasional good months. Across multiple longitudinal studies, remission rates averaged around 60% over 5 to 15-year follow-ups. That means the majority of patients saw sustained relief from core BPD. Features: enough that they no longer met diagnostic criteria. For a condition once thought immovable, remission in 6 out of 10 cases reshapes the fundamental story of what BPD means over time. But recovery is not all or nothing. It has levels. The same review distinguished between symptomatic remission and what researchers called excellent recovery. Symptomatic remission meant the absence of diagnosable BPD symptoms. Excellent recovery required more. The combination of remission with full-time vocational functioning and satisfactory social stability. About 39% of individuals met this higher bar. While that was lower than the 73% reported for other personality disorders, the figure matters because it highlights an overlooked truth. Nearly 2 out of 5 people once carrying one of psychiatry's most stigmatized diagnoses were, years later, working, maintaining relationships, and showing long-term stability. This is not a marginal sliver of hope. It's a significant proportion demonstrating thriving, not just surviving. Understanding what remission looks like also counters misconceptions about losing one's personality. Patients in recovery do not become flat or emotionless. Rather, the intensity, chaos, and instability that once drove every interaction fade. The fear of abandonment softens, the emotional storms calm, and relationships are no longer governed by sudden breaks and reconciliations. Life becomes more predictable, not in dullness, but in stability. It's less about erasing emotion and more about restructuring responses so that emotions can exist without derailing daily life. Recovery narratives are especially important because stigma tends to spotlight the most visible crises. Emergency hospitalizations, self-sabotaging relationships, and impulsive choices reinforce stereotypes. But the quieter stories of people building careers, raising families, or sustaining friendships rarely get amplified. When those stories are paired with long-term data from systematic follow-ups, the picture shifts. Recovery is not invisible because it is uncommon. It is invisible because it receives little attention. Still, acknowledging recovery doesn't mean ignoring the risks. BPD remains one of the most dangerous psychiatric conditions when left untreated. The World Psychiatry Review reported that roughly 75% of individuals with BPD attempt suicide at least once, and about 5.9% die by suicide across follow-up cohorts, far higher than the 1.4% observed in other personality disorders. These numbers establish suicide prevention as a central component of treatment and recovery planning, not an optional focus. Without addressing this elevated risk directly, recovery becomes less achievable. That dual truth, that many do recover, but many are at grave risk, underscores why both hope and vigilance must coexist in conversations about BPD. Physical health is another overlooked dimension of the recovery picture. People with BPD experience higher rates of medical comorbidities than the general population, including metabolic, cardiovascular, respiratory, and infectious conditions. These elevated risks extend beyond psychiatric difficulties into lifespan shortening. On average, people with BPD live 14 to 32 years, less than the general population. Men with BPD fare worse than women in life expectancy. Over a 24-year follow-up, 14% died from non-suicide medical causes, compared to 5.5% among people with other personality disorders. These statistics mean recovery for BPD cannot focus narrowly on mental health alone. A comprehensive approach integrates psychiatric treatment with medical care, lifestyle support, and early intervention for physical illness. Otherwise, progress in therapy may be overshadowed by preventable health problems. When viewed in this fuller context, recovery from BPD takes on greater nuance. It is not just a psychiatric journey, but a multidimensional process, emotional, social, and physical all at once. Someone who seemed trapped in cycles of self-destructive behavior in their 20s may, with therapy and support, build stability by their 40s, hold steady employment, and raise a family. Their life no longer matches the stereotype, yet they may still face health vulnerabilities that need attention. That dual reality is what long-term studies capture. Improvement in symptom stability alongside ongoing risks that require ongoing care. This recognition helps reframe what success means. Recovery does not need to be measured against an unreachable standard of perfection. Many people who achieve remission continue to experience mood reactivity, but those shifts no longer overwhelm them or destroy their relationships. In that sense, recovery is more about finding consistency than eliminating every difficult feeling. By realigning expectations in this way, patients, families, and clinicians can measure progress by lived stability rather than unachievable absolutes. Narratives of recovery also protect against therapeutic pessimism. A generation ago, many professionals avoided working with BPD patients because they assumed poor outcomes were inevitable. Data-driven hope changes that outlook. When evidence shows that 6 out of 10 will reach remission, and nearly 4 out of 10 will achieve excellent recovery, stigma no longer matches reality. Highlighting those outcomes shifts treatment culture from avoidance to engagement. It also encourages patients to stay invested in therapy by offering a realistic expectation of progress. Bringing personal experience into this picture makes it more concrete. A person who once cycled through emergency rooms in their 20s may now reflect on a stable marriage and a long-term career 2 decades later. Another may describe reduced emotional turbulence and stronger social ties, even if occasional sensitivity remains. These outcomes disprove the notion that recovery is fleeting. They demonstrate that remission can last through decades of adult life, reshaping identity and contribution in meaningful ways. As recovery stories gain recognition, they also highlight the importance of visibility. Awareness campaigns, support groups, and educational efforts increasingly feature first-hand accounts. Hearing these stories alongside statistics reinforces the point. Recovery is possible, attainable, and already happening for many. Integrating those narratives into public understanding helps counter outdated myths and encourages earlier, more compassionate treatment. Put together, the recovery picture is both sobering and heartening. Sobering because suicide risk and reduced life expectancy remain pressing challenges. Heartening because remission and excellent recovery are now well-documented realities. That combination presents a balanced truth. BPD is serious, lethal if neglected, but far from untreatable. With structured therapy, integrated medical attention, and persistence, outcomes can be dramatically better than stigma once suggested. And this shift in focus raises one more question. If so many are reaching recovery, what underlies that change on a biological level? For years, the assumption was that BPD symptoms reflected permanent brain changes, as though the pathways involved in emotional instability could never adapt. But new research suggests the story may be different, pointing toward mechanisms inside the brain that make this progress possible. Neuroplasticity, the brain's secret ally. For years, borderline personality disorder was described as if the brain itself were permanently scarred. Research showing differences in the amygdala, prefrontal cortex, and hippocampus seemed to paint a picture of wiring that was fixed, which reinforced the belief that change could only ever be superficial. Therapy, in that view, might build coping strategies, but the deeper brain pathways would remain untouched. The conclusion many drew was simple but discouraging. Recovery was biologically out of reach. That framework shaped how both patients and clinicians thought about the condition. Earlier imaging consistently showed an overactive amygdala, the emotional alarm system of the brain, which fired more intensely in people with BPD. At the same time, parts of the prefrontal cortex, responsible for regulating impulses and keeping emotional responses in check, were less active. This imbalance created what researchers called bottom-up control, responses driven largely by the limbic system, with weaker breaks from higher cortical regions. Beyond the amygdala and prefrontal cortex, differences were also seen in the hippocampus and medial temporal lobes, especially in people with trauma histories. These areas are linked to memory and stress processing, potentially explaining why early adversity left such lasting sensitivity. Some experiments even showed that people with BPD were more likely to misinterpret neutral faces as hostile or threatening, which fit with the intense interpersonal conflicts many reported. All of this supported the idea of a brain tilted toward misperceiving threat and struggling to regulate, a seemingly unfavorable setup for lasting recovery. By 2024, however, The conversation shifted when researchers reframed these patterns not as scars, but as circuits still capable of recalibration. This reframing comes from the idea of neuroplasticity, the ability of the brain to adapt structurally and functionally in response to repeated experience. Importantly, the evidence does not suggest instant or guaranteed rewiring. Instead, longitudinal imaging studies show that in many patients who engage in structured therapy, change is detectable in the very systems once thought frozen. Emotional reactivity didn't vanish, but regulation pathways began to compensate. Psychotherapy was not only teaching skills on the surface, it was associated with measurable changes in the networks themselves. Dialectical behavior therapy has provided some of the clearest data here. Studies have tracked patients undergoing DBT and found enhanced communication between prefrontal regions and areas like the amygdala after months of treatment. Behaviorally, this fit with reports of improved emotional regulation and reductions in crisis behaviors. Neurologically, it suggested that the new skills patients were practicing had become supported by stronger top-down connections. Mentalization-based therapy showed different, but related benefits. Patients receiving MBT improved at interpreting the emotions and intentions of others, reducing the tendency to assume hostility. In imaging studies, this improvement corresponded with shifts in how social cues were processed, hinting at recalibrated networks underpinning perception. None of these results prove permanent cure, nor do they imply uniform change across all patients. Neuroimaging studies are often small, vary in design, and sometimes produce mixed findings. Researchers are careful to say the evidence is promising but tentative. Larger, multi-site studies are still needed to confirm the scope of neuroplastic adaptation in BPD. But even with those caveats, the weight of findings supports an important update. Brain activity in BPD is not static. With sustained therapy over months and years, real changes occur in how the prefrontal cortex and the amygdala work together. Cognitive flexibility provides another piece of the story. People with BPD often perform more poorly on tests that require rapid mental shifts, impulse control, or flexible problem solving. Previously, those deficits were seen as hardwired. More recent findings show that targeted cognitive exercises and therapies can, over time, improve performance on such tasks. Once again, improvements do not appear overnight, but emerge gradually. Imaging shows those gains align with increased activation in cortical areas connected to executive functioning. In other words, therapy that feels like practicing self-control is also slowly training brain networks to strengthen where needed. Consistency is part of the equation here. The brain changes linked to BPD do not vanish after a handful of therapy sessions. Imaging studies suggest shifts build slowly, often requiring months of systematic practice, and results tend to stabilize as these patterns are reinforced. This parallels clinical recovery, where people move away from raw, effortful coping into a steadier baseline of regulation that feels more natural. Patients often report that what once required intense concentration has become automatically available, which is another way of describing how brain circuits adapt through repetition. Reframing the discussion around neuroplasticity alters how recovery is understood socially as well. If differences in brain activity are permanent scars, then stigma grows. Outsiders assume volatility and dysfunction are destined to last. But if those same circuits can adapt, then the conversation becomes more constructive. Instability can still be intense, but it is not forever, and brains can strengthen regulation through therapeutic training. The optimism comes not from wishful thinking, but from studies showing networks adjust when therapy is sustained. Variation among patients complicates this picture in valuable ways. Some experience early gains in emotional regulation, others improve more on cognitive flexibility, and some show reductions in interpersonal misperceptions first. This suggests that multiple circuits are involved, and that no single therapy targets all pathways equally. It also explains why hybrid treatment programs, drawing from DBT, MBT, Schema therapy, and others, are gaining popularity. Each approach seems to enhance different neural systems, and together they cover more ground, giving patients greater opportunity for change across domains. The link with early trauma also fits into this model. Childhood adversity may leave biological traces, such as amygdala hyperactivity and threat bias, but adulthood offers windows for recalibration. Consistent therapy can broaden prefrontal involvement, teaching the brain new options beyond those old stress-based responses. Rather than trauma writing an unalterable script, treatment shows that neural pathways remain plastic, even decades later. This aligns with remission studies demonstrating that many individuals sustain stability for years, a fact that makes sense if brain systems themselves have shifted to support regulation. Still, science calls for caution. The optimism that comes with neuroplasticity doesn't erase the fact that many imaging studies are underpowered and not all individuals respond equally well to therapy. The literature remains heterogeneous, meaning results vary across studies. But a realistic balance emerges. The brain differences central to BPD are genuine, often measurable, and strongly tied to symptoms. Yet they are not sealed against intervention. Therapy, consistently applied, is associated with functional improvement, and in some cases detectable structural change. The bottom line is clear: brain differences in BPD are real, but they can be changed. Therapy is the pathway to altering function, and those changes take sustained time and committed practice. This is why long-term engagement, rather than quick fixes, is the strategy with the strongest record of success. And while these findings help explain why recovery is biologically possible, they also touch on a more personal truth. The brain systems that adapt most are those involved in how people respond to others. Emotional regulation doesn't happen in a vacuum. It unfolds in relationships. And for BPD, those relationships remain one of the most visible and misunderstood parts of the entire condition. How BPD hijacks relationships. When people hear about borderline personality disorder, the conversation often turns quickly to turbulent relationships. To those nearby, the sudden swings in attachment and emotion can look like chaos. Love expressed with overwhelming intensity one moment, frustration or rejection the next. Partners, friends, and family members often describe feeling swept up in unpredictable surges of emotion that leave them confused, exhausted, and unsure how to respond. Misunderstandings arise easily, and without context, outsiders often mislabel these behaviors as manipulative or intentionally hurtful. But research shows that the root lies elsewhere: a heightened sensitivity to abandonment combined with difficulty regulating emotion. One of the most studied features helping explain these patterns is splitting. This defense makes it hard for someone with BPD to see both the positive and negative qualities of a person at the same time. Instead, loved ones can end up portrayed as either completely good or completely bad, depending on the emotional moment. For the individual, this split is not a conscious choice, but a reflex against overwhelming tension. That pattern alone can destabilize any relationship. Still, researchers note that it is not only splitting at work. Studies show that people with BPD also tend to score high in rejection sensitivity and often struggle with mentalizing, the ability to imagine and interpret another person's thoughts and feelings. These two tendencies combined help explain why even minor slights, like a forgotten text or slight shift in facial expression, can escalate into powerful emotional storms. The result is relational volatility that can feel bewildering from the outside. Take a simple scenario. A romantic partner misses a phone call after work. Instead of being neutral, the missed call is interpreted as proof of rejection. Within hours, the relationship might flip from closeness to suspicion, from trust to accusations of betrayal. What looks manipulative is in fact fueled by an intense fear that rejection is imminent and unbearable. The person with BPD may lash out preemptively, as if to shield themselves from worse abandonment to come. Ironically, that very reaction often pushes their partner further away, creating a cycle that reinforces the original fear. Families and close caregivers are often caught in the middle. A parent of an adult child with BPD may try to set simple boundaries, like asking them to handle their own appointments, but this can be experienced as withdrawal of support. A partner may claim a few hours of personal space, only for that request to be met as evidence of rejection or indifference. Over time, family members can start to feel like every decision is a potential trigger, walking on eggshells to avoid setting off emotional shifts. Without understanding, resentment builds. Well-meaning outsiders often say, "Just leave that relationship," labeling it toxic. But from inside, those bonds are not defined only by volatility. They also contain deep vulnerability and sometimes intense affection that makes breaking away far more complex. In 2025, researchers are emphasizing that interpreting these patterns as deliberate manipulation is misleading. The emotional reactions in BPD are real to the person experiencing them. tied to how their nervous system responds to potential threats of abandonment. Anger or despair may look outsized compared with the trigger, but the reaction feels catastrophic in the moment. Reframing the volatility as a symptom tied to fear of abandonment highlights that the conflict is not rooted in cruelty, but in dysregulated emotion. This perspective makes a difference. It reduces stigma and opens space for treatment and support instead of blame. Therapeutic approaches lean heavily on improving interpersonal effectiveness. In dialectical behavior therapy, for example, patients learn concrete skills for navigating communication. These include how to ask clearly for what they need, how to validate others while holding firm boundaries, and how to spot the role of emotional triggers before reacting to assumptions about intent. Group therapy often helps reinforce these skills by practicing real situations people face, waiting for a text response, handling a cancelled lunch plan, or hearing unexpected criticism. Through repetition, what once felt like proof of abandonment comes to be understood as ordinary uncertainty. Mentalization-based therapy approaches the same problem from a different angle, building curiosity about what another person may be thinking or feeling, rather than assuming the worst. A partner not answering a call, for instance, may be in a meeting instead of preparing to leave the relationship. Pausing long enough to question one's interpretation before reacting can change the entire relational outcome. Both DBT and MBT use variations of this principle, which can be distilled into a simple takeaway even for those watching this video. When someone you love reacts intensely, try asking a clarifying question instead of assuming intent. This small shift, checking, "Are you upset with me?" rather than concluding, "They are abandoning me," is a validated technique from these therapies and can de-escalate conflict before it spirals. Support for relatives and caregivers is equally important. Psychoeducation, structured information about BPD patterns, splitting, and abandonment sensitivity, helps families interpret behaviors differently. Instead of taking every accusation or sudden anger as a personal betrayal, they can begin to see emotional outbursts as distress signals. Support groups designed for family members teach how to validate feelings while still protecting one's own boundaries, a balance that reduces burnout and resentment. Research shows that family psychoeducation not only lowers caregiver burden, but also improves patient outcomes by stabilizing the relational environment. Beyond direct family contexts, much of what is learned in BPD therapy has broader applicability. The strategies taught, slowing reactions, clarifying assumptions, balancing validation with firm boundaries, generalize into everyday life. Couples without BPD, co-workers in stressful environments, and even educators managing adolescent conflict can benefit from these lessons. While these methods were developed for severe interpersonal instability, the principles apply to all human relationships. Stronger communication, clearer boundaries, and less reactive assumptions. Over time, people with BPD who engage in structured therapy often report relationships transforming. The turbulence that once defined them gives way to more stable trust. Partners no longer feel they are bracing for the next explosion, and families begin to predict steadier interactions. Longitudinal studies support this reality, documenting that as emotional regulation improves, interpersonal turmoil diminishes. With consistent therapeutic work, bonds once marked by crisis shift toward reciprocity and resilience. Far from doomed, many of these relationships stabilize and endure. Calling these dynamics manipulative misses a key truth. What is happening is not calculated harm, but the collision of heightened threat perception with fragile emotional regulation. That mix can hijack relationships, pulling both sides into cycles of closeness and conflict. But evidence from 2025 shows cycles can weaken and stabilize with treatment. For loved ones, compassion and education are central tools. For patients, therapy offers new skills and new patterns. Tools not only for surviving relationships, but for sustaining them. One practical recommendation for viewers living close to these dynamics is to seek professional support. If your partner, family member, or even close friend repeatedly shows patterns of extreme swings in attachment and anger, consider reaching out for family psychoeducation or a therapy team experienced in BPD. These resources ease the pressure on caregivers, reduce stigma, and make it more likely relationships can move towards stability rather than collapse. Learning to view these challenging behaviors as signals of fear, not as deliberate harm, changes the way support is given and received. Communication, patience, and structured therapy shift what once seemed impossible into something manageable. And that shift in perception also opens a new challenge. In some communities, these same behaviors are framed through entirely different lenses, not as symptoms of a psychiatric condition, but as signs of something else altogether. That misinterpretation has consequences worth examining closely. The mistaken identity, BPD versus spiritual crisis? In some spiritual and New Age communities, the experiences linked to borderline personality disorder are sometimes interpreted as signs of transformation. Early stages of awakening, glimpses of transcendent insight, or sudden expansions of consciousness. Heightened emotional sensitivity, rapid changes in identity, and turbulent relationships might be reframed as evidence of a deeper inner shift. For someone hearing this interpretation, it can feel affirming and even liberating. But when those same experiences are actually symptoms of a mental health disorder, confusing the two can be more harmful than helpful. It may prevent people from accessing the kind of care that directly supports their safety, stability, and long-term recovery. The overlap is not random. Many spiritual traditions describe psychological upheaval as a step toward growth, suggesting that clarity often emerges only after chaos. Jung, for example, described individuation as a process that burns away illusions before uncovering wholeness. From the outside, emotional swings, identity shifts, and intense relational struggles in BPD can resemble this sort of breaking and rebuilding. An individual might feel like an entirely different person within hours, shifting from one self-image to another without continuity. In spiritual language, this could be described as ego loss or shedding of old identity structures. Clinically, however, the DSM-5 TR identifies this very instability in self-image and relationships as a diagnostic hallmark of BPD. Differentiating between these two interpretations requires careful attention to context, chronicity, and overall impact on functioning. Mislabeling BPD as awakening comes with a significant cost. In a spiritual framing, someone may be encouraged to trust the process or surrender to the shift. While such advice may serve a person in genuine spiritual exploration, it does not address the core dynamics of BPD. Fear of abandonment, chronic emotional instability, or impulsive behaviors that carry real risks. Dialectical behavior therapy, DBT, and mentalization-based therapy, MBT, exist precisely to help with these patterns. But if they are never accessed because the symptoms are mistaken for signs of spiritual growth, the risks of self-harm and suicidality increase. What was intended as validating guidance may become inadvertently dangerous when essential clinical support is absent. The reverse is also possible. People going through authentic spiritual crises can sometimes be misdiagnosed with BPD. Intense insights, altered states of consciousness, or powerful feelings of unity with something larger than oneself may be mistaken for fragmentation, identity disturbance, or dissociation. When that happens, individuals may be prescribed medication or labeled in ways that diminish their spiritual experiences. Instead of being guided toward integrating these moments as part of a meaningful journey, they may feel pathologized and cut off from exploration. This can leave them less trusting of both clinicians and spiritual communities, alienated from the very supports that could help. So how do we draw the distinctions? The first marker is chronicity. In BPD, symptoms are pervasive, appearing early in life, repeating for years, and cutting across daily contexts. Intense emotions and unstable identity are not confined to isolated events, but are part of a lifelong pattern. In spiritual crises, experiences are usually time-limited and often linked to specific practices like meditation retreats, rituals, or profound life changes. They may be destabilizing in the moment, but typically move toward integration. Second is functional impairment. In BPD, destabilizing emotions disrupt work, relationships, and health consistently. Romantic partners describe endless cycles of closeness and rupture. Family members experience ongoing conflict and burnout. Self-harm behaviors or suicide attempts may emerge repeatedly. In spiritual crises, the distress is significant, but it doesn't consistently dismantle daily functioning across years in the same way. Growth is often part of the longer arc, even if the current moment feels disorienting. A third distinction is safety risk. In BPD, self-harm and suicidality are frequent and well documented. affecting up to 3/4 of patients across their lifetime. These are clinical red flags that signal the need for structured intervention, regardless of any spiritual framing. Conversely, spiritual crises typically involve profound shifts in meaning and identity, but do not inherently carry the same recurring patterns of self-injury. Finally, dissociation and transient psychotic symptoms must be considered. Individuals with BPD may experience depersonalization, derealization, or brief stress-related paranoia. These features complicate relationships, heighten conflict, and amplify confusion. Genuine spiritual crises can also include altered states, but when such symptoms escalate into ongoing dysfunction or threaten safety, they align more closely with clinical diagnostic categories than with healthy transformation. With these markers in mind, one practical checklist can guide decisions about whether to seek clinical assessment or lean more on spiritual mentorship. If experiences A. persist over years instead of days or weeks, B. cause disabling impairments in work or relationships, C. include self-harm or suicidal behavior, or D. involve dissociation or psychotic-like features, clinical evaluation should take priority. If these red flags are absent, but distress still occurs in a transformative context, then supportive spiritual guidance may be a valuable resource. The role of collaboration cannot be overstated. Mental health professionals and spiritual mentors each hold pieces of the puzzle. When they work together, people are less likely to be overpathologized or, on the other hand, left untreated. Someone navigating emotional turmoil that blurs the boundaries between psychological symptoms and spiritual growth is safest when both perspectives are respected. An integrated approach protects the individual's immediate health needs while also honoring their search for meaning, ensuring neither side of their experience is dismissed. What happens if these distinctions are overlooked? Two risks emerge. If BPD is misframed as awakening, individuals miss windows for evidence-based therapy and may spiral deeper into instability. If spiritual crisis is labeled disorder, individuals lose faith in their experiences and may carry unnecessary stigma. Both errors can leave people isolated and unsupported. That dual possibility underscores why careful evaluation by trained clinicians is essential whenever emotional intensity begins to endanger safety or daily functioning. Understanding these nuances also reduces blame and guilt. For individuals with BPD, recognizing that their turmoil does not signal hidden enlightenment, but a disorder that responds to structured care can be clarifying. For those with spiritual crises, knowing their experiences are respected rather than dismissed as pathology affirms the validity of their growth. Each path deserves its own kind of support, and each benefits from being recognized on its own terms. The larger message is that not all upheaval in identity or emotion comes from the same source. One form is a psychological condition requiring sustained treatment. The other is a temporary passage of meaning-making. Both involve intense inner processes, but one holds clear risks that demand clinical safety nets. Recognizing the difference is less about drawing permanent divides than about ensuring that people are not left untreated or misunderstood. Nuance matters because it helps individuals choose the right help at the right moment. This distinction also opens space for another step: learning what signs point clearly toward BPD in everyday life. Because beyond questions of spirituality or pathology, many people struggle simply to identify whether their own or someone else's patterns rise to the level of a disorder. Understanding those red flags can make the difference between brushing off behaviors as dramatic and realizing they point toward treatable symptoms. And that awareness is where the next part of the discussion turns: practical red flags, spotting BPD in daily life. In everyday life, many of the key warning signs of borderline personality disorder are easy to miss because they get dismissed as quirks of personality. People might hear someone described as dramatic, too emotional, or overly sensitive, without realizing that these scattered impressions might be signals of a broader, consistent pattern. What the 2025 diagnostic criteria emphasize is exactly this. BPD is not about one episode, one bad week, or a single impulsive choice. It's about enduring instability that shows up across self-image, mood, and relationships, starting by early adulthood and echoing across different areas of life. This consistency is what sets BPD apart from everyday ups and downs. Professionals identify the disorder by looking at 9 possible features laid out in the DSM-5 TR, and a formal diagnosis requires meeting at least 5 of those 9. That threshold is important because it underscores that spotting 1 or 2 warning signs is not enough. Instead, clinicians look for patterns repeating across time and context, piecing together a larger picture from different dimensions of a person's life. For those outside the clinical setting, the practical step is not to diagnose, but to recognize when these recurring red flags might suggest the need for a professional assessment. Some of the most noticeable red flags fall into a clear group that viewers can keep in mind. Rapid mood shifts are among the most defining. These are not minor swings from frustration to calm like most people experience. In BPD, emotions can shift sharply within hours, sometimes within minutes, plunging from closeness to despair or anger over what seems like a small trigger. A partner being slow to respond to a text may seem neutral to most, but for someone with BPD, it can feel like proof of rejection, sparking overwhelming distress. Another central sign is a frantic fear of abandonment. Even in secure relationships, the possibility that someone important might walk away is felt as an ever-present threat. This can drive desperate behaviors meant to prevent perceived rejection. Excessive messages, begging a loved one not to leave, or even starting arguments in an attempt to maintain connection. To outsiders, these actions may appear clingy or manipulative, but they reflect an intense attachment sensitivity rooted in fear of isolation. An unstable sense of self is also common. While most people have a relatively steady identity, even as it evolves over time, BPD brings sudden fluctuations in self-image. A person may feel confident and capable one day, only to feel worthless and rootless a few days later. Values, career goals, or long-term plans can flip quickly, contributing to chronic feelings of emptiness. This identity disturbance often drives impulsive choices and disrupts relationships, because anchoring to a stable sense of self feels out of reach. Impulsivity is another significant warning sign, often expressed in at least 2 self-damaging domains. This might include reckless spending, binge eating, substance misuse, dangerous driving, or risky sexual behavior. These actions usually come as attempts to manage overwhelming emotions or fill inner emptiness. Relief may come briefly, but it is quickly followed by guilt or shame. What looks like irresponsibility to others is more accurately understood as a pattern of regulating emotions through risky behaviors. Recurrent self-harm or suicidal behavior is one of the most urgent red flags, and one that requires immediate attention. This includes not only suicide attempts, but also self-injury like cutting, burning, or threats of self-harm used as expressions of pain and distress. It is critical to take these behaviors seriously every time. They are not casual bids for attention, but reflections of acute suffering. Studies show the majority of people with BPD attempt suicide at least once in their lives, with a significant minority dying from suicide. Whenever suicidal ideation or recent self-harm emerges, the priority is immediate intervention, emergency services, crisis hotlines, or urgent professional help, rather than waiting for things to resolve on their own. Other signals may appear less dramatic, but carry heavy weight over time. Chronic emptiness, for example, is frequently described as a deep inner void that can't be filled despite relationships, jobs, or external achievements. The emptiness can drive compulsive searching, new hobbies, new partners, or risky behaviors, all in an attempt to fill what feels like a bottomless hole. There is also the presence of intense, uncontrolled anger, which may surface in explosive outbursts or simmer beneath the surface and disrupt relationships. Finally, transient paranoia or dissociation sometimes arises, especially under stress. A person may briefly feel detached from themselves, question what is real, or become intensely suspicious of others. These episodes can compound relational friction and further reinforce the feeling of instability. Condensed into a spoken list, the practical red flags to watch for are rapid emotional shifts within hours, a frantic fear of abandonment, unstable self-image, impulsive or self-harming behaviors in at least 2 areas, chronic emptiness, intense or poorly controlled anger, and short-lived dissociation or paranoia under stress. If you recognize several of these happening consistently over time, the next step is not labeling, but encouraging professional evaluation. Understanding these red flags helps reframe how behavior gets interpreted. Instead of branding someone as dramatic, manipulative, or irresponsible, patterns can be seen for what they are: possible indicators of a condition with evidence-based treatments and real pathways toward recovery. Families benefit too. Misunderstanding can trick loved ones into thinking that every crisis is deliberate or aimed at them personally. Awareness makes it easier to respond with empathy and boundary setting rather than resentment. Recognizing red flags also reshapes the experience for those living with BPD. Many carry self-blame, convinced they are broken or incapable of stable relationships. Seeing their struggles as consistent with an established pattern can lighten the weight of guilt. It helps them understand that therapy, not shame, is the appropriate response. This awareness isn't just about reducing stigma in the abstract. It's about creating the conditions where people feel justified in seeking professional help instead of hiding behind labels like too sensitive or unlovable. At its core, spotting these patterns matters because it turns confusion into clarity. A person may feel trapped in cycles of conflict without realizing there's an explanation strong enough to unify their experiences. Loved ones might think instability is purely relational, missing the wider pattern that connects mood, impulse, and identity. By naming these red flags and knowing that 5 out of 9 define the clinical threshold, people can see why professional evaluation is essential. Without that clarity, treatment is delayed and the risks, including suicide, remain dangerously high. The safety note bears repeating. When there is active suicidal ideation or recent self-harm, this is never the time for careful observation or wait and see. It is the time for immediate action, calling emergency services, contacting crisis lines, or seeking urgent professional help. This is not only life-saving, but it also signals to the person in crisis that their pain is valid enough to be met with swift and serious support. Practical awareness of these recurring signs is less about handing out diagnoses and more about creating the conditions for people to reach the right help at the right time. By attuning to the signals, both dramatic and quiet, families, partners, and individuals themselves can shorten the delay between suffering and treatment. That gap is often where the most damage occurs. Closing it means lives can stabilize sooner, stigma weakens, and new paths open forward. If recognizing these patterns is the first step for individuals, the broader context spreads further. Because BPD is not only significant for those directly affected, but also for how it shapes the way society as a whole understands emotional struggle, relationships, and human vulnerability. And that wider significance is where the discussion moves next. The takeaway: why this matters for everyone. Borderline personality disorder is often framed as something that matters only to people carrying the diagnosis. In reality, it offers lessons that affect everyone. Understanding BPD changes the way we approach conflict, communication, and emotional intensity in daily life. The patterns most visible in BPD, sudden shifts in mood, fear of abandonment, and impulsive reactions, are extremes of experiences that most people will encounter at some point in relationships. Psychological literacy around BPD equips us with tools to handle those moments better, whether or not a diagnosis is present. The challenge is that myths still shape how people respond. Misunderstanding sustains stigma, and stigma narrows how society interprets emotional expression. When intense feelings are seen only as manipulation, or when an unstable sense of self is dismissed as weakness, it strips away compassion. These assumptions quickly harden into stereotypes: that people with BPD are untreatable, that recovery is almost impossible, or that relationships with them always fail. But these myths spill over. They affect how we treat anyone in our lives who seems emotionally vulnerable. Eliminating stigma isn't about correcting abstract statistics. It's about improving how all of us engage with those around us. By 2025, research points toward a clear corrective. BPD is not defined by a single flaw, but by a complex interaction of heritable vulnerabilities, environment, and ongoing brain adaptation. Understanding that removes much of the old blame. It is not about finding fault with individuals or families, but about asking what forms of support make recovery possible. Seen this way, emotional volatility looks less like selfishness and more like an outcome we can respond to constructively. That reframe benefits families and workplaces just as much as patients. It encourages healthier interactions built on patience and communication rather than judgment. Health systems are beginning to reflect this shift with updated guidance. In November 2024, the American Psychiatric Association released new treatment guidelines for borderline personality disorder. These guidelines emphasize 3 core principles: person-centered care, a documented and comprehensive plan for each patient, and collaborative discussions about diagnosis and treatment. In other words, transparency and partnership replaced the older, paternalistic model where patients were told what would happen with little explanation. Including patients in diagnosis discussions and providing psychoeducation not only improves outcomes, but also lowers stigma by treating individuals with respect. The guidelines also make crucial clarifications about medication. For many years, people with BPD were frequently given multiple psychotropic medications for extended periods, usually because clinicians felt unprepared to manage crises otherwise. The updated standards caution strongly against this approach. Medications should not be long-term or offered as the primary method of treatment. Instead, they should be time-limited, targeted to specific measurable symptoms, and always adjunctive to psychotherapy. In practical terms, that means medication may help manage crises like severe depression or agitation, but psychotherapy must remain the anchor of care. Families and patients benefit from understanding this balance. Progress hinges far more on structured psychological work than on ongoing prescriptions. The central recommendation remains consistent. Prioritize structured psychotherapy. Approaches like dialectical behavior therapy, mentalization-based therapy, schema therapy, or transference-focused psychotherapy have demonstrated effectiveness, whether offered alone or blended into hybrid programs. Each has strengths, from teaching skills for regulating emotions to reshaping identity and relationship patterns. Knowing that psychotherapy is the evidence-based foundation helps patients set realistic expectations for recovery and helps supporters understand where to focus energy. The second recommendation extends beyond psychiatry into integrated care. People with BPD face not only psychiatric challenges, but also increased risks of physical health problems, including cardiovascular, respiratory, and metabolic conditions. Long-term follow-up studies show elevated medical mortality alongside psychological risks. Addressing mental health without medical care leaves those risks unresolved. Integrated treatment, where psychiatric therapy is coordinated with physical health care, improves outcomes across the board. This means clinicians, families, and patients should advocate for care that looks at the whole person, not just mental health in isolation. These guidelines and recommendations matter because they create a different baseline for how we view mental health systems. Patients are no longer cast as difficult or hopeless cases. Clinicians are no longer left to manage crises. Without evidence-based strategies, families are invited into psychoeducation rather than blamed from the sidelines. The public absorbs a clearer message. When treatment is structured and supportive, recovery is not rare. Outside clinical settings, this knowledge reshapes how people interact with each other. Many of the therapy tools developed for BPD, clear communication, boundary setting, and the practice of holding two opposing truths at once, are transferable. Skills for emotional regulation are useful in classrooms, workplaces, and families. A teacher who interprets sudden anger as emotional overload rather than defiance can intervene in ways that calm rather than escalate. A manager who understands identity instability can create steadier support for an employee instead of punishing inconsistency. A partner, aware of abandonment sensitivity, can respond with validation and boundaries instead of simply withdrawing. These practical benefits connect to the broader idea of psychological literacy. To be literate, in this context, means understanding what symptoms mean and how to interpret them without defaulting to stigma. Intense emotions, identity shifts, or impulsive actions are not automatically evidence of malice or selfishness. They may signal distress, emptiness, or disorganized coping. When more people carry that awareness, they default to compassion and problem-solving rather than judgment. Psychological literacy makes conversations about mental health easier, lowers the barrier to seeking treatment, and diminishes shame. Communities that fail to build this kind of literacy keep repeating cycles of harm. People suffering in silence are dismissed as difficult or attention-seeking. Families face conflict rather than learning constructive ways to support one another. Schools and workplaces punish instability rather than accommodating vulnerability. Whole systems are weakened because stigma blocks recognition and treatment. By contrast, when psychological literacy spreads, support is given earlier, recovery becomes more visible, and everyone benefits from healthier patterns of interaction. These lessons matter at a cultural level as well. It is tempting to categorize people neatly. Some are mentally ill, others are mentally healthy. But framing mental health as a continuum of vulnerability and resilience recognizes that everyone negotiates emotional shifts, relational strain, and questions of identity at different intensities. In BPD, those struggles appear in their most dramatic form. But by understanding this extreme, society gains tools for moderating everyday struggles at smaller scales. Education about BPD becomes an education in how humans adapt to pressure, fear, and change. The learning extends into every facet of social life. The growing body of research and updated guidelines show that outcomes can improve, not only for individuals with BPD, but for whole communities that adopt openness and compassion. Seeing people with BPD reach stability and remission, despite the condition's reputation, challenges the pessimism that still surrounds other mental health diagnoses. If recovery is possible here, it signals the value of supporting recovery conversations everywhere. For viewers, two clear takeaways stand out. First, psychotherapy should always be prioritized over routine, long-term medication management. Structured approaches such as DBT, MBT, Schema therapy, and TFP consistently show the strongest long-term outcomes. Second, advocate for integrated care that combines psychiatric therapy with attention to physical health needs. When both mind and body are supported, the chance for lasting stability increases. If you've experienced stigma around BPD, whether directly or within your family, you're invited to share your perspective in the comments. Recovery and understanding benefit from open conversations, and your input may help counter myths for others. And if this topic resonates personally, consider bookmarking this video and starting a conversation with a clinician about evidence-based therapies. Asking about structured psychotherapy is one of the most powerful actions anyone can take toward change. Taken together, the research, the updated guidelines, and the visible stories of recovery leave us with a clarified message. Learning about BPD does not only affect clinicians or patients, it reshapes communities, families, and interpersonal dynamics everywhere. Better knowledge reduces stigma, pathways to treatment become clearer, and compassion is easier to access. The implications stretch far beyond a single diagnosis. And with that recognition comes one final insight about BPD that cannot be ignored. A reminder of what the most recent research confirms about its trajectory and possibility for change. Borderline personality disorder deserves to be understood clearly. The evidence shows it is treatable, with long-term remission occurring in roughly 60% of patients who receive appropriate care. Psychotherapy, not medication, is the foundation of progress. No drug is FDA approved for the core symptoms, and medication should only be short-term and symptom-specific. At the same time, recovery must be viewed realistically. Elevated suicide risk and higher rates of medical comorbidity mean treatment has to be comprehensive and safety-focused. If this video helped you rethink myths about BPD, please like, subscribe, and share it with someone who needs a more hopeful perspective.